This program is brought to you by Emory University.
Good morning, everyone. My name is Heval Mohamed Kelli. I was one of the research fellow, and right now in my final clinical year. I picked an interesting topic, fibrinolysis for acute STEMI, an old art in the modern day. I overheard Dr. Williams talking about that none of the fellow has done something on lytics and STEMI in the past 5 to 7 years. So I picked the topic, and although the only time I've seen anything about lytics and STEMI was in the board questions. So something that I wanted to learn more just for my own curiosity and knowledge. My talk is going to focus on 3 segments. I'm going to talk about the history and background of fibrinolysis and STEMI, and then I talk about the most common fibrinolytic agents, and then followed by some of the trials of PCI versus fibrinolysis, and then give you some summary of the ACCHA guideline. That was actually where the board is focused on. I have never seen a case, so I had to pull a question from the board to present this. So a 58-year-old male comes to a community hospital that's 90 minutes away from a nearest cath lab, 2 hours of substerone chest pain, ST elevation in V1 through V5, some ST depression and inferior leads. He takes warfarin for mechanical valve. His last INR 3 days ago was 3.2. So what are the most appropriate treatment option here? Aspirin, Plavix, half dose of Tenecteplase, followed by transfer to PCI. B, aspirin, Plavix, transfer to the PCI center. C, aspirin with tirofiban, and then D is aspirin, Plavix, heparin, and then Tenecteplase. And the answer lies here. This is the ASCC 2013 AHA guideline. Pretty much the way it describes here, if the symptoms are less than 12 hours and the PCI is going to be delayed by 120 minutes, that's where they recommend to give fibrinolytics. The patient was within 90 minutes, so pretty much you give aspirin, Plavix, and transfer to the PCI center. That was the answer for the case. Just basic overview. My talk is going to focus on the final progression of ACS, which is, as everyone knows, STEMI is pretty much a thrombus that completely occludes the vessel, causes transmural infarct. And that's what I'm going to focus most of my talk on, giving lytics in that setting. We have to talk about some of the pathogenesis of atherosclerosis. As everyone knows, there's endothelial dysfunction, setting of risk factor of hypertension, diabetes, and smoking, and others that causes some proliferation of the smooth muscle, activate some of the macrophages to come in, engulf these oxidized LDL and cholesterol particle, creates foam cells that eventually causes fatty streaks, which is the early sign of atherosclerosis. Over time, these macrophages in the smooth muscle cell create this matrix around this fatty streak that becomes a fibrinous plaque. And they also release these metalloproteinases that actually digest the fibrinous cap, and it becomes so thin that eventually rupture, and the collagen is exposed to the bloodstream, which actually activates the thrombus creation, which leads to either end STEMI or the STEMI when there's a complete occlusion of the vessel. Just to understand how these lytics work, it's important to understand what a clot is. Clot is a form of platelet, thrombin, and fibrin, and that's where all the therapy of ACS is focused on. So platelet activate prothrombin to thrombin, which activates fibrinogen to fibrin, that creates the matrix where the platelet aggregate with the blood cells, and that's how the clot is formed. This is a little busy slide and figure, but actually this puts all the therapy of ACS in one figure. As you see on the left, there's the aspirin, focus on the antiplatelet aspect of ACS, and then you have the coagulation cascade where we give low molecular heparin, which actually prevent the progression of thrombin. And then my talk is going to focus mostly on the fibrinolytic pathway, where most of the lytics focus on pretty much on activating plasmin to plasminogen. We as a human have natural fibrinolytics as the tissue plasminogen activator, which is known to be TPA, and then urokinase plasminogen activators. They pretty much work on the plasminogen conversion to plasmin, which furthermore break down the fibrin matrix and then dissolves the clot. And that's what all the therapies are focused on. Here are our natural fibrinolytic agent. Urokinase was discovered in a human urine in 1947. Is not an antigenic and is direct activation of plasminogen to plasmin, furthermore break down the fibrin. We do have our own TPA, which is produced by the vascular endothelial cells. it has a very significant fibrin specificity and affinity, which means fibrin has to be present for it to work. And it actually binds to the fibrin surface with plasminogen and converts it to plasmin, which furthermore breaks down the fibrin matrix. What I was looking for a picture for natural lytics, this is actually, you could buy this, is the vascular roto-rooter, which is supposed to be a natural clot buster that you could take every day. So we have to be aware to tell our patient this is not a doctor-formulated clot buster that replaced lytics. The history of MI, I think it's important for us as fellows that we don't see fibrinolytics, that we have to actually respect for the therapy, given the history of MI and how we got to where we are today. 1768, that was the first time when angina was actually described as this pressuring chest pain, goes, comes on with heavy exertion, then it goes away. 100 years later, 1880, Carl Weger actually shows association between coronary occlusion and MI that causes the myocardial infarction. James Herrick voiced the importance of actually giving bed rest for people for a few days after having acute MI. Furthermore, they recommended the use of morphine for easing the pain, which is not something we should be doing now. That was in 1928. In 1940, they found this oral anticoagulant from spoiled sweet clover, which is called dicamerol, and it was given to patients with acute MI with some modest success, but of course, it was the complication, a lot of bleeding complication what happened during the time. In 1950, where they discovered aspirin for preventive therapy, but actually was not used for acute treatment. So Dr. Tinsley Harrison recommended that when people have an MI to give them IV hydration and oxygen in addition to bed rest and morphine to help some of the patient to recover. So until then, the treatment plans was a palliative treatment. We didn't have a curative treatment and a good dose of thought and prayer for the patient to actually do better. And in 1960, they introduced the concept of the CCU, which actually did help decrease a lot of the mortality in patient post-MI. So the Tillett experiment, I think this was the breakthrough that started the whole fibrinolytic era. In 1933, Dr. Tillett and John Hopkins was observing this experiment. He had these 5 tubes. He put in there human plasma in there, but in tube D and E, he put in the streptococci, and then he throwing calcium in all the tube, clot was formed. Over time, he noticed that the tube D and E that has the streptococci, actually, the clot dissolved. And that was something that he started thinking about. There must be something in those bacteria that's released that actually breaking down the clot. This is the history of lytics, and just to have some understanding. So as you see before, I talked about 1950, we had only just palliative treatment for acute MI. In 1933, where Dr. Tillett discovered the concept of streptococci producing fibrinolytics that causes fibrinolysis of the clot, back all the way to 1945, they were able to isolate streptokinase, and then he recruited his students to run some of the trial on streptokinase and MI, Sol Sherry. What they did is they were able to get New York University to give him some of the protein of streptokinase to give it to patient, and they were giving to patient with acute MI, but the problem is they had a lot of pyrogenic reaction. The protein was not purified that well, so it was causing a lot of hypertension, bleeding, people having an antigenic reaction to the mixture. In 1982, TBA actually was discovered, and then 1988 to 86, there were a lot of trials done on streptokinase, when it eventually was put in a guideline to be used as an effective treatment. And I blocked out anything after 2000. It was a PCI era came in and took over. So. In 1980s, Dr. Brownwall and LaFell actually came up with a protocol when streptokinase was used in America. They pretty much say you have to do an arteriogram of the both coronary vessel and do an LV gram, and if the patient condition is stable, you give him an intracoronary infusion of streptokinase through a catheter. They showed some success, but 80% of the patient who actually was successfully perfused, they had actually slow VT. And then they figured out they did some studies on IV option of giving the streptokinase, and it was similar efficacy with less actually complication in the patient. And that's where the concept of giving streptokinase IV instead of going to the coronary was implemented. So what are the common fibrinolytic agents? I'm going to focus on the 4 common ones that have been used throughout the history of fibrinolysis. First, of course, we have to understand is actually this non-fibrin specific, which is streptokinase, and it doesn't require fibrin activation for it to work. The rest of the fibrinolytic to all focus on fibrin specificity, and they do, if there's no fibrin present in the bloodstream, these fibrinolytic don't actually work, so they have very limited impact. Here's some of the graphs showing that streptokinase actually works without any fibrin activation. It binds to the plasminogen and causes a conformational change that activates plasmin and therefore break down the fibrin. The rest of the things like alteplase, which is TPA, and others work with fibrin combination. There has to be present a fibrin for it to break down the clot and be activated. Here are the common doses of the four most common fibrinolytics. And this is something that we can see, but I want to point out the reason why tenecteplase is very commonly used in the standard of care compared to everyone else is given actually over 5 to 10 second infusion. So you give it right away, it's very effective. Everyone else, every other drug or fibrinolytic requires at least 30-minute to an hour infusion be given. So streptokinase is something I mentioned. That was one of the first lytics that was discovered. Is a single polypeptide derived from the beta hemolytic streptococcus culture. The dose is given over 60 minutes. It's actually given with aspirin and heparin. Some of the trials supported that. But the problem with it is very antigenic and causes a lot of allergic reaction. And people who receive streptokinase, they found out that up to 7 years, they still have the antibodies. So there is actually, when they give it second time, there could be a high risk of having a reaction. And it does cause, in addition to bleeding risk, it causes hypotension during the infusion. One of the first trials that put lytics on the map and actually kind of like helped it to be part of the guideline, it was the GC trial. As you see from the name, it was done in Italy. It was 11,000, almost 11,000 patients. Everyone was receiving streptokinase versus placebo, and anyone who presented with less than 12 hours was suspected MI. At 21 days, overall mortality was significantly lower in patients who got streptokinase. As you see, 10% versus 13% in a control group. This is the paper actually was published in 1986, and this is actually the table that shows it. If you see that almost less than 6 hours, there was actually a significant benefit. After 6 hours to 12 hours, there almost no significant benefit between the control and streptokinase. And then furthermore, if it was given less than 1 hour, it has the most impact and benefit in patients with acute MI. And furthermore, like 10 years later, they did a 10-year follow-up of the same trial, and people who were treated within 1 hour still had a benefit at 10 years. So 1 hour was kind of a good market. Everyone else beyond the 1 hour didn't show much of a benefit, but the people who received the streptokinase within 1 hour, they had up to 10-year survival benefit compared to the control group. And then the second trial, which I call it the most unfortunate trial name, the ISIS-2, it was 7,000 patients within 24 hours with symptoms. They were given either aspirin, streptokinase, with aspirin, with streptokinase alone. And this trial was important because it showed that patients who received aspirin with the lytics showed the biggest impact. And this was the first trial that showed the clinical benefit of aspirin mortality with people presented with acute MI. So that's one of the trials that actually put aspirin on the map in acute MI. Furthermore, the next drug that came out was Alteplase, which we call a TPA here. It's a fibrin specific. It binds very strongly to plasminogen to convert to plasmin. It has a very short half-life, 3 to 4 minutes. Some of the trial that put the Alteplase on the test was a GC2 and an ISIS-3. They showed no difference between streptokinase and Alteplase given with or without sub-Q heparin. So the thought process was like, they didn't see any benefit, and the question came, should we give patients instead of sub-Q heparin, IV heparin, and test it? Maybe there was something problem with the sub-Q heparin given to these patients that there was no benefit. That's where the Gusto-1 trial came out. Big trial, 41,000 patients, 1,000 hospitals, 15 countries. It showed 1% absolute reduction in 30-day mortality for people who received TPA versus streptokinase. And the greatest benefit actually were in people less than 75 and an anterior MI. And sub-study was done, an angiographic sub-study showed that actually TPA had a significant greater likelihood of a better TIMI grade 3 flow in those patients. And as you see here, they break down the patient to streptokinase with IV heparin, streptokinase with sub-Q heparin. The combination therapy was streptokinase, TPA, and IV heparin given at the same time. All of these, they didn't show much benefit, and you see the TPA actually had the most significant benefit with IV heparin given. And then when TPA came out, people thought about how about giving the combination of a front-loaded or accelerated regimen. Pretty much the goal was to give 100 milligram over 90 minutes, and that was the protocol that standardizes TPA. Usually you start out with 50 milligram bolus, followed by 0.7 milligram per kilogram over the next 30 minutes, and then for the next 60 minutes, you give 0.5 milligram per kilogram with a total dose of 100 milligram over 90 minutes. And the COBALT trial actually tested the ask as should we give double TPA to patients, see if it's better to open up the vessel and cause, there was actually higher mortality and stroke when a patient was given 200 milligram TPA versus the 100 milligram recommended dose. So what are the risks, what are the complications of TPA as we all could predict? 1.8 has severe bleeding in the Augusto trial percent. 11% had moderate bleeding, which means they actually did require transfusion, and it was all related to the procedure of giving the TPA. 1.4% had a stroke, but almost half of these people who had a stroke actually died, had a fatal stroke. And then previous TIA and CVA were at higher risk, up to 6%. So just to go through some of the early trial summary of the initial lytics that were discovered, there was an absolute mortality benefit, mostly actually 3% within the first 6 hours of symptoms presentation. There was a 30% reduction in short-term mortality, let's say within 30 days. Alteplase had a 1% survival advantage compared to streptokinase, and the greatest benefit was people in less than 75-year-old. And those benefits did persist for 10 years. Now I'm going to go into the two more modern lytics that were discovered. Reteplase, which we don't see as often, is less fibrin selective, has a longer half-life than TPA. The clinical trial eventually showed there was a similar outcome with Reteplase and TPA. There was actually a high incidence of TIMI grade 3 with Reteplase compared to TPA, but there was also fewer additional coronary intervention were needed within the first 6 hours if you gave Reteplase versus TPA. But of course, they needed a trial to prove the efficacy of Reteplase. The Augusto 3 trial was also a trial of 15,000 patients of giving TPA versus Reteplase. At 30 days, actually, there was no significant mortality benefit or stroke, and no difference at 1 year. The Augusto trial was designed to be a superiority trial, but actually did not show any support as hypothesis. Further trial was done, the INJECT trial, about 6,000 patients. It compared Reteplase to streptokinase instead of TPA. They all received IV heparin with the treatment plan, and it showed no difference in mortality. The only thing it shows there was few cases of cardiogenic shock and heart failure incident, people who received the Reteplase infusion. And now we go to the drug that we all hear about and familiar with. Tenecteplase was a genetically engineered mutant of TPA. It has a longer plasma half-life, and actually 14 times more specific to fibrin, and has an 18-fold higher resistance to inhibition of the plasminogen activity inhibitor. As you see here, the infusion is given, and this is something that I saw a question on our in-service exam here. It usually is given about, if patient less than 60 kilogram, you start a 30 milligram dose, and every 10 milligram above that, you add a 5 milligram up to a dose of 50, which is the max to be given. The first trial that tested Tenecteplase was a TIMI-10B trial, which actually compared the efficacy of 2 doses compared to TPA. They looked at the primary TIMI-3 flow at 90 minutes. At 50 milligram of Tenecteplase, there was a higher intracranial hemorrhage, but at 40 milligram, they had the same complication rate as TPA, but lower with 30 milligrams. So 40 milligrams seemed like to be the ideal dose for Tenecteplase compared to TPA. And then the ASCENT-1 trial shows that wanted to test the safety profile of Tenecteplase doses 30, 40, and 50. They showed actually there's no benefit in stroke and hemorrhage bleeding compared to prior trial, and it was very comparable to TPA. And then the ASCENT-2 trial, which almost was used about 16,000 patients, there was no difference in mortality when compared in 30 days compared to TPA, and actually was a lower bleeding risk and lower need for transfusion in people who had received tenecteplase compared to TPA. And given in mind, also tenecteplase is given over 10 to 15 seconds versus TPA has to be given over 90 minutes infusion almost. So these are late trial summary, which is a summary. There was a review of all the 38 small trials and big trials together. We looked at Reteplase, Tenecteplase, and Reteplase. I don't want to talk about it much more because we're not using that. So I found that the efficacy and safety profile were actually all similar to TPA. Tenecteplase is the easiest fibrinolytic to use as a single dose of a few seconds. And the Gusto-5 and Ascent-3 trial tested the concept, should we give half a dose of fibrinolytic with G2B3A inhibitors to show if there was associated few ischemic event. But however, there was no mortality benefit and a much higher risk of bleeding if it was given with the G2B3A inhibitors. So that was kind of not recommended anymore to be, the concept was not implemented at that time. Here's a summary of the 3 common lytics that we use in they're familiar to our modern era. And I just want to point out again that the fibrinolytic specificity for tenecteplase is the highest. They both, Reteplase and tenecteplase are actually a mutant of TPA. And pretty much if you look at the dose given here, I just want to point out that 90 minutes versus 30 minutes versus 10 seconds. So this is why made tenecteplase becoming one of the most commonly used lytics in the US and North America. What are the contraindications? Everyone knows the contraindication if you had a previous intracranial hemorrhage, any lesion in the brain, malignant neoplasm, a stroke within 3 months, that's something that's tested, dissection, of course, active bleeding, and a trauma to the face, that's a closed head trauma within 3 months. What are the relative contraindications? Usually a blood pressure systolic above 180 and ischemic stroke above 3 months. And when I mean relative contraindication, it has to be a discussion with a team of putting the risk and benefit. One thing I point out, if it was CPR, then over 10 minutes, usually is not recommended to be given any lytics, major surgery, and a prior streptokinase infusion. So this goes back to what the few slides I presented that is very entogenic, so given it a second time, it causes like an entogenic reaction. Pregnancy actually is a relative contraindication and use of anticoagulation. So the initiation of therapy of lytics, how do we think about it? There's the concept of pre-hospital fibrinolysis. It's recommended that first contact with the patient that start thinking about giving it within 30 minutes. There were some studies done on like giving it in an ambulance to the hospital, but this was concept that's supposed to be based on some trials, and a meta-analysis was done to show that it's a short time to give in lytics and also reduce all-cause mortality in patients who had pre-hospital infusion of the lytics. The timing is important, and that's what I wanted to focus on. What is the most benefit of giving lytics, and what is the best time to give it? As you look at this graph here, after 3 hours, the benefit actually drops down tremendously. So the greatest benefit of the trial showed that within 4 hours, the most benefit given to the patient, and it's best within 70 minutes. There was a mortality, after like 12 hours up to 18 hours, there was actually less mortality benefit. There was no significant benefit in patient to receive lytics. And there was an ongoing chest pain and you have no access to a PCI center, up to 24 hours, you could still consider giving lytics to these patients. There's some trials show some of the benefit in those patients. What is the choice, the agent of choice? As I mentioned, tenecteplase. Talked about the dosing on the left. And just remember, a vial of 50 milligrams is about $2,200, the cost of the infusion of tenecteplase. So what are the limitations of fibrinolytics? The greatest benefit is within the first 4 hours. After that, the benefit drops down. And it shows in the earliest trial in streptokinase that after 6 hours, actually, there was no significant benefit against the control group. There's only 50 to 60% of people actually obtain TIMI grade 3 flow versus PCI, which is up to almost 96%. The early occurrence of ischemia is up to 20 to 30% in people who receive lytics. There's major complication about 2 to 3%. And then 20 to 30% of STEMI patients actually are not candidate for fibrinolytics based on the contraindication I presented, like stroke, hemorrhage, uncontrolled hypertension. And they're not effective in cardiogenic shock on prior CABG. So that brings it down to like almost about 30% of the STEMI patients are not eligible for lytics based on some of these contraindication and then no benefit in these patient profile. So I'm going to further now go into like the era of when PCI was introduced and how it compared to fibrinolysis. And I think that's going to make the interventional guys happy because, as you could expect, the results now. The earliest meta-analysis of 10 randomized trials showed that using, primary PCI with balloon angioplasty against fibrinolysis, there was lower mortality at 30 days. There was lower rate of death and non-fatal in reinfarction. There was lower rate of stroke in patients who had a balloon angioplasty versus fibrinolysis. The PAMI trial was one of the first trials actually that looked at the primary PCI with angioplasty versus 100 milligram of TPA, which is a recommended dose. It was about the smaller trial, 395 patients who present with acute MI within 12 hours of onset. There was similar benefit and complication rate in the people who had a balloon angioplasty. The high-risk group, who are above 70 years old, had an anterior MI with an elevated heart rate, actually could drive the most benefit from the balloon angioplasty against TPA. This is some of the trial, and I listed all of them by looking at fibrinolysis with PCI with stenting. The stent PAMI and the Cadillac showed that there's stenting people compared to angioplasty show the greatest benefit in AMI. And all the trials that I listed, the DYNAMI and the Prague trial and the others showed that there was a better outcome with stenting compared to fibrinolysis. I'm going to focus only on two big trials that kind of reinforced the concept of stenting versus fibrinolysis. As a DYNAMI trial, it was 1,500 patients almost received TPA versus stenting. The study actually was prematurely discontinued because there was a significant reduction in mortality, reinfarction, and stroke for people who received PCI versus TPA. And as you see that in the graph on the right, there's a big difference in mortality benefit versus lytics versus the people who received PCI stenting. And actually, there was a study that was published in September that looked at a 16-year follow-up of the DYNAMI trial and showed there's still major benefit of people who received PCI stenting versus the lytics. The Prague trial, of course, was done outside the United States. 850 STEMI, less than 12 hours. They did receive streptokinase versus PCI stenting, and it also showed there's a lower mortality at 30 days in people who received the stent against the lytics. And it persists for 5 years. And I wanted to plug the graph. When all patients compare against each other, of course, you see the black is where the people received the streptokinase, they had a higher mortality. But at 3 hours, they had similar mortality benefit. But after 3 hours, as you see, the PCI group had a much lower mortality compared to the one who almost like doubled down on a lytics patient, which reinforced the concept that lytics are actually effective within the first 3-4 hours of given to patients who are eligible. And then later analysis of the DYNAMI trial looked at a patient and they stratified them based on the TIMI risk score, which is a component of these 8 various risk factor and presentation of the patient. And they wanted to look at like higher risk versus low risk patient. And then as you look at it, the higher the TIMI score, the more risk of mortality goes up, of course, because these patients are usually sicker and have more comorbidities. In a 3-year follow-up, the DYNAMI trial showed that there was actually a reduction of mortality in people who actually received PCI versus lytics if they had a TIMI risk score above 5. But the people who between 0 and 4, which consider low risk, there was no benefit between the two interventions. So TPA or a PCI would have similar benefit in these low-risk patients. So there was this concept developed, the pharmaco-invasive therapy. Let's say you got lytics because you're eligible. Should we do a routine PCI right after that as part of the therapy? The Gracia trial showed about 212 patients given tenecteplase followed by stenting within 3 to 12 hours. There was a similar versus people who just received PCI within 3 hours. It did show there was a similar 6-month mortality, so there was no reason to do the combo pharmaco-invasive therapy. PCI with stenting was sufficient enough to give the same benefit versus fibrinolysis followed by stenting. And as you see in the graph, there was no mortality benefit between the two groups. The FAST-MI trial wanted to look at 1,700 patients, primary PCI versus fibrinolysis followed by PCI with a no reperfusion. There was also no significant difference in the people who received the stenting versus people who received fibrinolysis followed by stenting. And then also the 5-year mortality was similar too. So I'm going to go now focus on the STEMI guideline and what I think for us as fellows also to like just reinforce the concept after all these trials were done. What is the ACC and AHA 2013 trial talks about? And an update from the resuscitation trial of AHA 2015 was similar to this too. So this goes back to the first question I presented. People who cannot receive a PCI or is delayed more than 120 minutes, they're recommended, and they present with a symptom less than 12 hours, they're recommended to give lytics. There's a 1A classification. And people who had an ongoing ischemia for 12 to 24 hours is almost a 2A. And for anyone with ST depression, except with true posterior MI, there's actually a harm to actually give lytics in these patients. What about the adjunct antithrombotic therapy we give to therapy to patients with fibrinolysis? Aspirin is a class 1A. Everyone who gets lytic has to get an dose of aspirin. It's between 162 to 325 milligram. And also recommended to give Plavix, and this is where age plays a role. Less than 75, you give a 300 milligram loading dose of Plavix followed by 75 milligram daily, up to 14 days and 1 year in absence of bleeding. If it's above 75, you don't give a loading dose. You just actually give the 75 milligram with the lytics. What about heparin and anticoagulation? Again, is recommended as a class 1A to CMB. What I noticed that the enoxaparin actually is 1A indication to given with the lytics. The only thing between the fondaparinux and Lovenox we know is a creatinine, so less than 30 is recommended to give heparin infusion. What about what does the guidelines tell you when transfer patient after they receive lytics? When do you send them out? The class 1B indication is if the patient develops cardiogenic shock or any heart failure symptom, is actually a 1B indication transfer to the hospital. If there's an urgent transfer for a failed perfusion, the patient develops chest pain and has persistent STEMI, ST elevation on EKG is a 2A indication. So. And also, it's a 2 indication to send patient who, within the 24 hour after successful fibrinolysis. So it's up to the hospital and then the consultant team to discuss the patient stability to send him to a PCI center within the 24-hour presentation after receiving lytics. What about the indication for an angiograph, having doing a cath on a patient who received lytics? Again, it goes back to the previous trial. If someone has a sign of cardiogenic shock or heart failure is a 1A indication, pre-discharge, if they still have an intermediate to a high-risk finding on a non-invasive testing, is recommended to do an angiograph on these patients. And a spontaneous and early provoked myocardium ischemia also is an indication. These are all one between B and C indication for these patients. Now, if there's a failed perfusion or occlusion, is a 2A indication transfer to a PCI center. And for stable patient is based on a discussion with the team. What are the indications for a PCI actually of an infarcted patient received fibrinolytics? It is recommended in people who actually, again, cardiogenic shock or heart failure symptoms and 1B indication. And it goes back to the previous one. Also, if people had a non-invasive test before discharge, it shows them they still have intermediate to high-risk finding. It's recommended for them to actually do have an angiograph and then in PCI if it's needed, of course. So, and then one thing is about delayed PCI in people who has a total included infarction after 24 hours of STEMI, there's no benefit, which is a 3B indication. So the summary of the trials and then all the things I talked about here, fibrinolysis still remains an important actually treatment plan for many hospitals don't have actually PCI capacity. And the focus is if you can't get a PCI within 120 minutes, you're actually supposed to give lytics. And as we know, in a rural area, that's something that is implemented because I think I looked at the data, more than 50% of local, rural hospitals don't have access to a PCI center within 120 minutes. Streptokinase is actually still the most commonly used in the world because of this low cost. Tenecteplase actually is a fibrinolytic agent in the US, Canada, and many countries in Europe. There's a significant limitation to the fibrinolytic therapy when compared to a PCI intervention, as all the trials are presented earlier. And the greatest benefit for actually lytics is within the first 4 hours. Let's keep that in mind. Thank you very much. And I will open the field. I'm glad that some of the more experienced cardiologists who've been in the era of lytics would like to get their reflection or a question from the crowd. Thank you.
Some local history on this deal.
Okay.
Thank you. If you started back when this streptokinase came to be given first locally, and then you started talking about giving it down the coronary arteries, and a guy named Peter Renfro reported, I don't remember now, maybe Steve or John remembers, but maybe 15 cases. And he had like a 95% success rate using this. So we tried, Andreas Grunzig said we ought to try this ourselves, and so we tried to do this, giving it in the coronary arteries. And our success rate was like 30%. Just it couldn't seem to make it work. Now, we invited Peter Renfro to come down here and talk about it. Peter's view was the only thing we're doing wrong is we're not giving enough heparin. We need to give more heparin. But about that time, I should say there was one other thing that came before that time, and there was the question of, was an infarct and the thrombus in an infarct the consequences of the infarct, or was it the cause of the infarct? And there was a guy named Bill Roberts who was out in Dallas, whose brother was a radiologist here. Bill Roberts was a leading cardiopathologist in the country at that time, and he swore that the occluded coronary artery was a consequence of the thing and not the thing we should be treating. Subsequently, it's proved to be wrong on that. And then back to the story about streptokinase, we were part of the Gusto trial and tried to, do that. And the big advantage of that it showed was that intravenous thrombolytics were just as successful as trying to deliver it down the coronary artery. Those things all occurred in concert with the Gusto trial. There was that 40% attack done, and all these things led up to the fact that we could not prove that it would work in anti-coronary. That's when about that time we started doing sub-Q.
It's interesting, you mentioned the natural fibrinolytic processes that our bodies have. A decade or so ago, we didn't have many tools to deal with thrombus in the cath lab. So if we saw a big clot, we might put the patient on heparin for several days, or maybe it was a really big clot, put them on heparin for several days and Coumadin anticoagulation. So you guys may remember Philippe Albuquerque. He's one of our fellows from a year or so ago. And so he called me up the other day and sent me a picture of a patient he had with a gigantic coronary thrombus. And he was wondering what to do about it. And the problem is if you try to suck it out, and you embolize it to the brain, it's a huge deal. So I suggested he, basically keep the patient on heparin for several days and then anticoagulate the patient. And he did that and brought the patient back in 3 weeks. And it was totally gone. So we do have that innate ability to lyse clots to a degree.
So I remember trying to decide how long it had been since the infarction, like time to arrival. And that was always difficult to define. And I've been interested in this stuttering infarction-like pattern. If you have a patient that comes in with chest pain, their enzyme's up a little bit, and they don't have much going on, then sometimes you'll maybe have STT changes. Then the next day you walk around to the floor and the troponin is like 20. It says, oops. So I've been interested in that group, and they're out there. It's always hard to time, say, within 120 minutes. Well, within 120 minutes of what? It's not so easy to determine. I remember struggling with that. The other thing is, if you rely on ST segment elevation to make the diagnosis, which we were kind of forced into because, like, legally, So, well, if the ST segment, no, that's the way you diagnose an acute infarction. Therefore, you have the criteria to give thrombolytic therapy. And but what about the ones that come in with the ST segment depression? There was something you had up there, a posterior infarction, which is relatively silent, and there would be a group of people that would come in with, and even now, with what I call an acute posterior infarction. And, you know, we don't take them to the cath lab, or we don't give them thrombolytic therapy. And I've seen them die while we're kind of delaying till the next morning or something like that, when they have occlusion of the circumflex. That's what I call a true posterior infarction. You get the opposite changes in V1, V2, V3. Then there's a patient that has a stuttering infarction and has what we call isoembolism. That is, the plaque has ruptured and the blood is exposed to tissue factors that result in thrombosis and platelet and fibrin deposition, but it doesn't totally occlude the vessel. Flow is down the vessel and diastole, then little clots form there, and they shoot downstream to the branches, and you look at the angiogram, you see a partially occluded vessel, and you see the distal vessels are occluded down the diagonal or down at the apex of the LAD. So, you know, those patients are out there too, having infarction. So those situations are outside the ST segment elevation ones. Now and you got to try to recognize them and take some action early. Who knows, maybe heparin will help them. Thrombolytic therapy will certainly help them. You know, if you think about what the neurologists do, you know, they say that they have like a 45-minute window to treat somebody with a stroke. They have trouble figuring out when the stroke occurred also. You know, they'll take them, they found that up to 24 hours now they can take them and sometimes get some return of that neurologic function. So, so this is an interesting story, and we ought to all know about it. And I appreciate you bringing it to the forefront.
You know, in the early days of balloon angioplasty, we had a lot of abrupt closures. So we would be working during the day, and we would balloon dilate an artery, and it looked fairly good. We'd watch it for a while and then send the patient back to the floor. Well, somewhere, you know, like 8% or so of the darn things would occlude. And we were always challenged to try to figure out who to bring back to the cath lab. And doing a bedside EKG is very helpful because, you know, particularly with an LAD or big right coronary, you get ST segment elevation. But we learned pretty quickly, as Steve mentioned, that the circumflex can occlude, and it's silent by ECG. So we would have patients who had, you know, at 8 o'clock at night would have chest pain, and we're trying to decide whether to take them back to the lab or not. Well, if it's a LAD or right and there's no EKG change, you're probably okay. But if it's a circumflex, you just had no choice. You have to go right back to the lab with them. And frequently we found the circ was occluded.
Well, it's interesting, you know, when you travel internationally, you see the dominant world is using streptokinase, and it is sad that companies that make Tenecteplase, they have not lowered the price, because I see so many patients, I mean, large number of patients getting streptokinase in the world, which we know is inferior to Tenecteplase. I mean, forget the angioplasty because they don't have the facilities. And so everybody gets streptokinase, and everybody gets cath after they bring the mom or dad to the city, you know, where they can get a cath after 2, 3, 4, 5 days, and everybody gets the artery opened up, whether they have a chest pain or not. And that is for different reasons, you know, I mean, financial and other reasons. But it is sad that companies that make Tenecteplase for altruistic reasons have not been able to feed the rest of the world with something price-wise that is as cheap as streptokinase.
So the clot burden seems to me to be very important. And, you know, I can remember when we used to go around and find a right coronary artery full of clot and start giving streptokinase down the vessel or TPA down the vessel, and this giant train-like clot would start floating down the vessel like that. And the clot burden, to my way of thinking, has to do with how long it's been since the onset of the event. If you got a vessel full of clot, you may say, well, it's within an hour. Well, let me tell you, it's within several hours. And if the ST segments are elevated on the EKG, I usually show the house officers this and says, okay, here are the ST segments elevated in the inferior leads. What do you think the vessel looks like? Well, almost always that vessel at that point in time is occluded, 100%. Now, what's beyond that occlusion has to do with how long it's been there and what kind of results you get. So getting to them early is important. And we used to call what John is talking about is double jeopardy. You know, they get thrombolytic therapy, they would seem to open the vessel up, they would come down, and next thing you know, they'd occlude it again. So double jeopardy. So, you know, we're losing the ball game, but then again there. But so it's been an interesting history there from the early 80s all the way through the 90s and where we are now. But the other thing is, you know, how do you define what rural is? Heval, what's your definition of rural in Georgia? Do you have a definition of that? Like
Outside of 285? I'm not.
I will say that will appear all over the boards, that whole question of the patient that is not in a PCI hospital and a 120-minute delay. And that probably applies to, you know, a large segments, the Dakotas, you know, and other places in the Midwest that are remote. But that there will be about 4 or 5 questions on that, and lytics is the correct answer. But Steve's point's well taken. When you break it down and you say it started at X point, I struggle with defining the onset of a symptom and deciding when to go. And the other big thing during those trials for the anticoagulants really is the streptokinase advantage was that it was longer acting, and the heparin adjunct and aspirin adjuncts are very important. So getting that right and monitoring it is extremely important as well.
Thank you very much.
The preceding program is copyrighted by Emory University.